Malaria, we have four species. Nowadays they said five. The incubation period of this malarial parasites are 10 to 14 days. The the presentation of the child is mostly likely adult. The fever with paroxysm, chills and rigor, fatigue in between. No focal examination, no throat, lungs, no spleen, liver, nothing. Most of the good amount of time. But some cases, in long-term cases, in worst cases, you do have anemia, you do have splenomegaly. Cerebral malaria is possible. The CNS involvement symptoms, AKI, acute kidney injury, black water fever, once upon a time very common in this part of the world. Algid malaria, the malaria with circulatory failure because of collapse of the circulation, circulatory collapse by dint of the massive hemolysis and bleeding. Metabolic acidosis, pulmonary edema causing dyspnea, retinopathy, and neurological neurocognition impairment is possible in 25% of cases. Hyperactive malarial splenomegaly was once upon a time common. Many of the low and low middle income countries. So these are the presentations. You diagnose the malaria by thick and thin film, and MP malarial parasite detection by Jameson stain and blood film, and at least three films should be examined before saying no malarial parasites 12 hours apart. So three film of thick and thin film is still the gold standard at 12 hours apart on the year. Apart from that, the theoretical PCR and ICT for malarial parasite, they also can be done. Binox now and malarial rapid immune absorption test, aldolase based test, they have high sensitivity, more than 90% to your up to 99% your sensitivity. And treatment of these cases are your current drugs is the usually the chloroquine sensitivity is was there in some of the parts of this global resistant cases are growing, and in that way chloroquine resistance is important. And chloroquine sensitive cases you do treat with the 10 milligram per kg at 5 milligram at 6 and 24 hours for 2 to 3 days something. Total dose 25 milligram per kg. Patient not responding to the chloroquine or the endemic resistant zone, you give quinine sulfate. And along with the, if you give doxycycline, tetracycline, or clindamycin, either of the three, response is said to be good. So 10 milligram quinine your per kg twice daily for 3 to 7 days. Patient becoming febrile in 3 shots of the with 3 doses of your quinine or chloroquine, whichever you give, is said to be diagnostic malaria. Apart from the plenty of the your diagnostic modality, this is a clinical diagnostic way. The other newer drugs, newer not this a few years, quite in decades, even the artemether, your and the lumefantrine, 20 milligram artemether and 120 milligram lumefantrine. Combination of these two has was one in one tablet. You give it for 3 days in 6 doses. The patient will respond. The patient who are not chloroquine sensitive, mefloquine can be used, and then your atovaquone or progonil, melatonin can be used, and then severe malaria you have to admit IV and IM antimalarial like artesunate and artemether, again 3 doses 12 hours apart. And quinine can also give an IV. Once upon a time we gave plenty of quinine IV injection and with good result. And the eradication, the dormant hepatic status eradication can be achieved with primaquine. Chloroquine and mefloquine or atovaquone can be used with proguanil combination, can be used as chemoprophylaxis when someone is traveling from the low prevalence zone to the high endemic zone.